I'm not going to talk about the DCIS stuff, but I'll talk about that later. So today I was just going to talk about the experience that we've had with using intraoperative radiation for reirradiation in locally recurrent breast cancer. So just briefly to go through background, we know that overall the 10-year incidence of isolated ipsilateral breast tumor recurrence is about 10% from numerous clinical trials. And that, however, overall survival is not different for women who do develop an in-breast tumor recurrence that's more than 5 years out from their primary treatment. So there's definitely an option for salvage. The standard of care, this is salvage mastectomy, and this is due to unacceptable toxicity if whole breast radiation is to be delivered, including fibrosis, rib fractures, pain, etc. So, however, even with mastectomy, there is still a rate of local failure. So numerous studies, these are older studies, have shown that you do get chest wall failure in about 3 to 32%. This is just a nice summary from a review in the Red Journal that looked at these older studies that mostly date from the 90s and showing that range. So obviously, perhaps there's other alternate ways of approaching this, and patients don't always want to have a mastectomy. The other important point of this is that the overall survival is still excellent. So if we do breast conservation alone, unfortunately, local failure is much worse. So to do surgery without some form of radiation for breast conservation is not a good option. Here we're looking at about 19 to 50% recurrence rates. So the idea of doing partial breast irradiation is not new. Most of the studies that have looked at this have actually been using brachytherapy. There is one older study that looked at external beam, and then the majority are brachy, like I said. And overall, the local control from the more recent studies show that with breast conservation and brachytherapy, you get local control rates that are in the 90s, which are quite good. However, this is not an easy procedure to undergo, so there's some resistance, and intraop is another alternate. Now, I think it's important to mention the RTOG 1014 study. This is the external beam, so it's a phase 2 study that looked at repeat breast conservation with partial breast reirradiation using external beam. This is 45 gray that was delivered BID over 3 weeks. They recruited 58 patients. Half of them had DCIS previously, half had invasive disease, and they've now reported their 3-year in-breast recurrence rates. This was reported at ASTRO in 2016, and they showed that they had 2 events, or 3.7% local recurrence. And then they just recently published their acute toxicity, and this is just more for reference in comparison to intraop. They see about, they had 4 events of grade 3 or worse late toxicity, which was fibrosis, infection, or 2 seromas. And interestingly, they reported their overall breast conservation rate as 95% approximately. So they did have 4 mastectomies, 2 of which were not for recurrent disease. So briefly, I'm going to go through our experience and then talk about what else has been published. So we have, as an institution, been doing intraop since 2013. We've treated about 243 patients at the time that we went back and looked. 12 patients have undergone reirradiation. These are all patients who refused salvage mastectomy. So they did not want to go, and they also declined external beam when we discussed that as an option. So this is just giving you an idea of who these patients are in terms of their primary diagnosis. Majority of these women had breast cancer initially, so they had an in-breast recurrence, which was either a new breast cancer, a new primary, or a recurrent disease. We did have 2 cases of women who had a history of Hodgkin's disease and had gotten mantle radiation. And actually, one woman had stage 3 lung cancer, had finished local radiation, chemoradiation for her lung cancer, and on her follow-up CAT scan actually had a breast cancer identified. So she didn't want to have aggressive management of that. So in terms of the reirradiation, the time to recurrence is actually quite long, as you would expect, except for the one case, which was the lung cancer patient. And in terms of what the cancers that we saw, these were all small, for the majority were small, invasive disease, hormone receptor positive. And then in terms of the size, majority of them were small, though there were 2 outliers. And again, most of these women are elderly or had competing comorbidities and actually really just didn't want to get mastectomy or didn't want external beam. So as far as follow-up, we have a short median follow-up. We've only looked 14 months at this point. We've had no local recurrences or distant recurrences, and all patients have not have been able to preserve their breasts. And then there was one patient who, with comorbid disease, actually died of heart failure, which was completely separate. In terms of toxicity, overall it's extremely well tolerated. This is a table just showing the rates of mostly grade 1 or 2 toxicities. Most of them are grade 1, and they're very much what you would expect. We did have one late grade 3 toxicity, which was a wound infection that did require IND, but the patient still actually is very happy that she underwent interop. So despite that event, she's still happy. So then just in terms of the published IORT experience, so there's a few papers that have been published. This is from a paper that just came out in 2018 from the German group that summarizes nicely the existing literature. And essentially these are all small studies. 2 of them are using the interbeam system, 2 are with electrons. And overall, they show that the local recurrence rate is, generally speaking, very low. The median follow-up is fairly short for all, though the last one, which I'm going to go into more detail, is at 5 years. And overall, it seems to be very well tolerated. And this is quite comparable, I think, to what we've seen in the other approaches for partial breast irradiation. So this paper is the one that I'm referring to from the group in Germany, that they just published their 5-year outcomes for using intraoperative radiation for recurrent breast disease. And I thought this was a nice paper. It's very similar, their patient population. They treated 41 women, and it's very similar to what we had seen. But basically, their local recurrence rate, their 5-year local recurrence rate was they had 3 patients who had recurrence, which gave them a local recurrence-free survival rate of about 90%. And in terms of, oops, this came out a little funny. Whoops. Sorry. So on the left is the metastases-free survival. Actually, so 7 patients did develop metastases, so that gave them a 5-year metastases-free survival rate of 79.7%. I think that's because there were a few more aggressive patients, more aggressive disease. And then in terms of, they've had 9 patients who've died. So an overall survival rate, which is 83%, which again is comparable to what you see in the other partial breast papers. These are small studies. And then they did a nice job of reporting their toxicity. This is from a subset of the patients they treated, looking at 15 patients, and reporting that they had no acute grade 3 or 4 toxicities. And when they looked at their late toxicities, overall, it's very well tolerated, and in the paper they just report that they had 4 patients with fibrosis that was grade 2 or greater, and 4 patients with significant breast pain. So the conclusions from this is that it appears that breast conservation combined with IORT is feasible. I think you have to be careful with patient selection. We, as a routine, salvage mastectomy is the first thing that's offered. I'm not going to suggest that this is the primary management. The acute toxicity is actually very minimal, so it's well tolerated. I think we definitely need more follow-up to look at late toxicity, and then local control and overall survival, from what we know in these limited experiences, is reasonable, but obviously more data needs to be obtained. So that's it.